Good day. Today we're going to discuss some new insights related to maternal mortality and HIV and contraception. We know that in South Africa, the main direct causes of maternal death are non-pregnancy infections, hypertension, and hemorrhage. But apart from these, there are two overriding factors. And one is the increasing rate of caesarean sections, and the other is the very high rates of unintended pregnancy. Certainly where we work in the Eastern Cape, 2/3 of babies born are from unintended pregnancy. So if we look at all the modifiable causes, we have the need to reduce caesarean sections to work on the direct causes, but probably the area in which we can have the biggest impact on maternal mortality is reducing unintended pregnancy. So I've just quickly noted some of the things that need to be done for caesarean section. There are problems related to lack of access where we need health service strengthening, but more often there are too many caesarean sections, and there are interventions such as childbirth companionship, midwife-led care, which may reduce caesarean section, and there's a real need for a randomized trial to clearly define the benefits and risk of elective caesarean section. For hypertension, we know that calcium reduces the risk of preeclampsia, and we need to look at approaches such as food fortification. And for early diagnosis, we need to look at innovative approaches such as blood pressure and home dipsticks monitoring to pick up hypertensive disorders as early as possible. For postpartum hemorrhage, again, delayed treatment is a major cause of mortality. We're involved in the emotive trial and also in development of a blood loss monitoring device so that excessive blood loss can be detected quickly and before there is irreversible shock. In situations where postpartum hemorrhage doesn't respond to initial treatment, we're looking at we're researching different tamponade methods and comparing balloon tamponade, which is the current standard approach, with vacuum tamponade using a simple Levine tube for what we call suction tube uterine tamponade. We won't talk about HIV today, but we'll go straight on unintended pregnancy. And here the key issue is access to contraception. And there are some areas where there is room for improvement, particularly the availability of implants, possibly introduction of the levonorgestrel implant, which may have some advantages over the etonorgestrel implant, which we're currently using in South Africa. There are new technologies for making injectable contraception more accessible to women, such as the self-administered subcutaneous depomedroxyprogesterone acetate, so that instead of women being dependent upon being able to get to a clinic every 3 months and the clinic having and being able to administer the intramuscular DMPA, the woman can be supplied with 1 year or even 2 years of contraceptives, which she can self-inject every 3 months. The WHO has recognized postpartum insertion of the copper intrauterine device as one of the areas in which the biggest impact can be made on unintended pregnancies. But this is something which needs very specific training and strategies to ensure that this technology is available to women who give birth. And we will also discuss today some techniques related to the insertion of the intrauterine device at. So just to complete our list of ways of reducing mortality, we will talk also a bit about the interface between HIV infection. We'll talk about the increased risk of HIV in relation to contraception, and we will talk about the ECHO trial and further research which we are involved with. So It's likely that non-barrier contraception increases risk of sexually transmitted infections, including HIV, because, of course, women using non-barrier contraception have less motivation to use the condom as a method of preventing pregnancy. However, for women who choose to use contraception, what is relevant is not the absolute risk, but the relative risk of different contraceptive options in terms of the risk of acquiring HIV. For several decades now, it's been thought that depomedroxyprogesterone acetate, or depoprogestogen, may specifically increase HIV risk, because we know that it certainly increases simian immunodeficiency risk in monkeys. It's known to suppress immune resistance to HIV through its glucocorticoid receptor stimulation. And observational studies have shown a fairly consistent 50% increase in HIV acquisition in women who choose to use DMPA. Of course, observational studies don't just show an association. They don't prove causation. There may be other factors relating to the choice of that method which place women at greater risk of HIV. However, this concept that DMPA was thought to be to place women at greater risk of HIV infection was so strongly held that many considered that randomized trials to answer this question would be unethical. However, we postulated that quite apart from the well-known effects whereby DMPA might increase HIV risk, it might also have counterbalancing protective effects. And these might include, for example, reduced sexual exposure related to the changes in hormonal status in the woman using DMPA, and also reduced risk of exposure to HIV during menstruation, because there is evidence that total exposure during menstruation increases the risk of sexually transmitted infections, and this might include HIV. Some years ago, in the Effective Care Research Unit in East London, we conducted a pragmatic randomized trial in which women after pregnancy termination who, after full counseling, consented to be randomized were randomly allocated for ongoing contraception, either with the copper intrauterine device or with injectable progestogens, which were mainly DMPA, but in about 15% of cases, norethistérone enanthate was used. And they were followed for a median of 20 months. The main outcomes were pregnancy and HIV. So looking at the HIV acquisition, we found no significant difference in HIV acquisition between the IUD shown in blue and the DMPA or injectable shown in brown, both with the intention to treat analysis and in the per protocol analysis. So this was reassuring in terms of suggesting that DMPA does not have a overall effect on increasing HIV risk compared with a non-hormonal contraceptive such as the intrauterine device. What was interesting when we looked at the reasons why women changed their method of contraception, it was clear that with the IUD, pain was a more common cause, and more of them had non-specific causes. Whereas with the injectable progestogen, the main reasons for changing were firstly amenorrhea, which many women like, but some women don't like, and therefore change because of that side effect. But very interesting, a large number of women using injectable progestogen stopped because they were no longer sexually active. And this was an indication of the possibility that the hormonal effects of injectable contraception may actually reduce sexual or exposure to HIV by reducing coital activity. We subsequently participated in the Evidence for Contraceptive Options and HIV Outcomes trial, which is a very large trial in 13 sites in Southern Africa. And the primary result, this is just showing the very large number of people who were involved in this study. It was a huge undertaking. The institutions that were in the study protocol was published in 2018. In the study, almost 8,000 women, young women, who were desiring contraception and were prepared to be randomized, were randomly allocated to DMPA intramuscular, the levonorgestrel implant, or the copper IUD, and they were followed 3 monthly for up to 8. The main outcomes were, first of all, HIV infection, and there were no statistically significant differences in HIV infection between the 3 arms, ranging from just above 4 per 100 women years in the with DMPA to about 3.3 with the implant. But these differences were not significant, and they fell within the margin of non-inferiority which had been determined for this trial. Pregnancy was somewhat more common with the IUD, but this was mainly because there was more discontinuation of in the IUD arm than in the other 2 arms. As part of the study, blood samples were collected from the women in the trial, and at the Effective Care Research Unit site in East London, we conducted hormonal studies on these samples, measuring testosterone, sex hormone binding globulin, free testosterone, and estradiol, both at baseline and at 6 months. And these results have not yet been published, but were very interesting in that, as one would expect, at 6 months, estradiol was significantly lower, both with the DMPA in blue and with the implant in green, compared with the IUD in brown, because progestogens are very well known to suppress endogenous estradiol levels. When it came to testosterone, the total testosterone levels were also lower than with the IUD in both the DMPA and the implant group. But what was most striking, and which I don't think had previously been shown, is that sex hormone binding globulin was also reduced with DMPA and with implant, but was far more reduced with the implant than with the DMPA, with the result that the biologically active levels of free testosterone were significantly lower with the DMPA than they were with the implant. DMPA was somewhat below the IUD level and implant somewhat above the IUD level, but DMPA free testosterone was significantly lower than with the implant. And of course, reduction in testosterone, as with reduction in estradiol, may well be related to sexual activity and could account for a reduction in coital activity and therefore HIV exposure in women, particularly in the DMPA group. So the conclusions of our study were that the almost 30% lower free testosterone level with DMPA than with the levonorgestrel implant might impair sexual function, mood, and bone health as well. May be beneficial in terms of reducing side effects such as acne, hirsutism, and alopecia. but could also explain the lower sexual exposure with DMPA, which was documented in the ECHO study, and lower exposure balancing the known immune HIV susceptibility with DMPA may account for the similar rates of HIV acquisition between DMPA, the copper intrauterine device, and the levonorgestrel implant in the. We're currently involved with the Women's Health Injectable Contraception and HIV study, which results are not yet published. This is a collaboration between Effective Care Research Unit in East London and Match Research Unit, or Match Research Unit in Durban, both of which are associated with University of the Witwatersrand. We randomly allocated actually 520 women to DMPA versus norethisterone enanthate, and we conducted hormonal studies at baseline and at 25 weeks. That is 1 week after the 24-week injection of either DMPA, which was administered every 12 weeks, or NET-N, which was administered every 8 weeks. The reason for this study is that there is a sound theoretical basis on which to hypothesize that HIV risk with norethisterone enanthate might be clinically meaningfully lower than HIV risk with DMPA. And the reason for this is that whereas both DMPA and norethisterone may be protective in terms of creating amenorrhea and reducing the risk of coital exposure during menstruation, and also possibly reduction in coital activity, NET-N differs from DMPA in that it does not have the immune suppressive effect, which might increase HIV susceptibility. In the current study, the sex hormone binding globulin was suppressed more with NET-N than with DMPA, which indicated that in this respect, NET-N may be more similar to the levonorgestrel implant, but we are still awaiting the results of the testosterone assays. It's quite plausible that the sense of well-being due to high free testosterone may account for the higher acceptance of levonorgestrel than with the etonogestrel implant. Moving on now to contraception and how we improve the access of women to contraception. We've created a very simple counseling guide because the most important aspect of contraception is counseling. And it really is quite important that women are given a very full explanation of the different options available to them and how effective they are and what side effects they can expect, so that women are able to make an informed choice of which contraception they would prefer to use, because the more they're able to choose a contraceptive of preference, the more they're likely to be able to continue with that method and therefore to avoid unintended pregnancies. What's most important about contraception is it cannot be left to the contraceptive experts. It cannot even be left to obstetrician and gynecology departments. It's the responsibility of all health practitioners, because contraception is one of the most important preventive measures that are available to us in the field of medicine. And every health practitioner should be in a position when providing care for women in the childbearing ages to ask whether they are planning to become pregnant, and if not, whether they're using effective contraception, and if not, to be able to counsel them and offer them access to contraception. So The first two slides on our contraceptive counseling guide are a very brief summary of the medical eligibility criteria, the WHO medical eligibility criteria, which make it possible for one to just quickly scan through if one has a woman with any medical complication or condition, to be sure that when we offer a method of contraception, it's not one which is contraindicated according to the WHO medical eligibility criteria. I won't go through these in detail. They're all listed here. So there's this one second slide which identifies which methods should be avoided under certain medical conditions. But for the most part, we are dealing with healthy young women without medical conditions, and therefore can counsel them about all the important methods. And so in our counseling, we can actually show this guide to the woman and go through it with her. And we would introduce the counseling by saying, we want you to know about all the contraceptive methods available to you to help you to choose the one which you prefer. First and foremost, we talk about condoms because they are extremely important to protect against sexually transmitted infections, but it's essential to understand that they are not that effective at protecting against pregnancy. And if women want to be sure to be protected against pregnancy, it's best to use condoms, but in addition, to use an additional method which is more effective. Of the many methods that are available, there are three common long-acting methods, and these are the hormonal injection, depomedroxyprogesterone acetate, DMPA or Depo. The other one is the levonorgestrel implant, which is the 2-monthly injectable contraceptive. There's the hormonal implant, either the Nexplanon or the Jadel, or the single rod implant Implanon. And thirdly, there's the copper intrauterine device, sometimes called the IUD or the loop. And then in addition, we have short-acting methods such as the pill. All of these methods are extremely commonly used and have been used for many years and are used by millions of women. So we really have good evidence that these methods are effective when they're used properly and are safe. First of all, the DMPA injection. This is injected into the muscle of the upper arm or the buttock. It's given every 3 months, and it contains the female sex hormone progesterone. The implant consists of either 1 or 2 small soft rods, which are inserted under the skin of the arm, and they provide protection. The 2-rod method is registered for 5 years. That's the levonorgestrel implant, and the etonorgestrel implant is registered as effective for 3 years. But there is, in fact, very good evidence that the single rod, the etonorgestrel, is highly effective for up to 5 years. And so it may be continued off-label with careful explanation if women prefer to keep it for 5 years. These implants release a female sex hormone, progesterone, similar to the DMPA, and therefore have fairly similar side effect profiles to DMPA. The copper intrauterine device is made of plastic and copper. It's inserted through the vagina into the uterus or womb. It can be inserted at the clinic or after miscarriage or birth or during a caesarean section. And the commonly used copper T380A is registered for use for 10 years, but has been shown to be effective at least for 12 years. It can, however, be removed at any time if the woman wishes to become pregnant or wishes to discontinue using it. The oral contraceptive pill is a contraceptive taken by mouth. It must be taken every day, and most pills contain both estrogen and progestin, female sex hormones, although there is a mini pill which has only the progestin. We can then ask the women whether they are interested to learn more about any of these options, and if they are, we can go into a little bit more detail. And I'm not going to go into that detail now. I'm just going to flip through the guide that we can use to describe these methods in more detail. We have the DA bit about is what side effects and the key. Similarly, for the implant, what it is, how effective it is, side effects which may be, what to expect when it's inserted, the key things to remember about it. The copper ID and the explanation of what it is, and some more information about it, how effective, what side effects may be experienced with it, and what to expect during the insertion of the IUD, and the key things to remember about the IUD. Similarly, for the oral contraceptive pill, what it is, how effective it is, what side effects might be experienced, the key things to remember about the contraceptive pill. We then also mention female sterilization and emphasize the fact that it can be done quite conveniently at caesarean section. And the important thing about this is that all pregnant women should be counseled during the antenatal period about whether they would like to have a sterilization done should they require a caesarean section, because even if they're very low risk and intending a normal birth, one can never predict when complications may arise, for example, during labor, and an emergency caesarean section may be needed. And this is absolutely the wrong time to have to counsel a woman about an important decision such as tubal ligation or sterilization. So it's very important as part of our antenatal care, apart from offering interval tubal ligation, which is one of the contraceptive options, but specifically to say to women, if for any reason you end up having an emergency caesarean section, would you like to consider making the decision now that you would like to have a tubal ligation, so that you can make that decision carefully and in discussion with your family. Male sterilization is another option to be explained to couples, and it's a very simple procedure with very low risk to the procedure, and is again highly effective as a method of contraception. And then we should invite the women that we're counseling to ask any questions and to try and help them to make a choice of the preferred method of contraception. Postpartum contraception is an important aspect because it is something which has really been neglected until recently. And WHO have estimated that with proper access to effective postpartum family planning, up to 30% of maternal deaths and 10% of child mortality could be reduced by ensuring that couples space their pregnancies by more than 2 years. We know that most women who are within a year of giving birth would like to avoid a pregnancy within the next 24 months, but that 70% of them are not using effective contraception. So postpartum family planning can help women who have an unmet need to space and limit future pregnancies, and at the same time help lower rates of maternal and child death. In particular, the copper-bearing intrauterine contraceptive device can be inserted immediately after birth or up to 48 hours after birth, and progestin-only methods can also be initiated immediately after birth. So these are the important long-acting methods which can be used after postpartum: the copper intrauterine device, the progestogen injection, and the progestogen implant, as well as male or female sterilization. The advantages of the copper intrauterine device are first and foremost that they have no hormonal effects, and therefore they cannot have side effects such as thromboembolism, such as effect on mood, on weight gain, effect on the endogenous hormone profile. And so one can really reassure women that the copper IUD will not affect their body in any way. It has only a very local effect in the uterus. The other important advantage is that there's an immediate return to fertility after removal, and that a single insertion, although that does require some skill and some discomfort for the mother, can provide contraceptive cover for up to 12 years, and it may be left in place still after the menopause. It has lower rates of discontinuation also than other methods, mainly because continuation doesn't depend on repeated access to the health services, for example, to have a repeat injection given or to obtain a new supply of the contraceptive pill. The disadvantage of the copper IUD is that initial insertion requires a skilled provider and may be uncomfortable for the woman. There's an increase in menstrual flow and menstrual pain, particularly in the first few months, but that may be persistent. And there are, of course, rare specific complications such as uterine perforation. So in recent years, it's become clear that the intrauterine device may be used in a far greater variety of situations than was previously thought. And this should really reassure us that we can offer the IUD safely to most women, including women with HIV. The previous concerns that the IUD may cause serious genital tract infection was specifically related to the Dalkin shield, which was very widely used in North America and which had braided strings which acted as a wick and enabled organisms to track from the vagina up into the uterine cavity, and certainly did cause important and dangerous intrauterine infection. Current evidence with the intrauterine device, such as the copper T380A, which has a monofilament string, is that it does not increase the risk of genital tract infections or sexually transmitted infections unless there is an active infection at the time of insertion. And even in women who have an IUD in place and who acquire a sexually transmitted infection, that can usually be effectively treated with the appropriate antibiotics without the need to remove the intrauterine device. Post-abortion is an extremely convenient and important time to offer women insertion of the IUD. It's most commonly at the time of miscarriage. A procedure will be done, an evacuation of the uterus, and it's extremely easy at that time, and really doesn't add to the discomfort of the procedure at all to insert an IUD after completing the evacuation of the uterus. Of course, when there are signs of active sepsis, one should defer insertion of the IUD until the sepsis has been treated. In women who've had a complete spontaneous miscarriage where there's no need for manual vacuum aspiration of the uterus, IUD insertion can nevertheless be offered as a specific procedure prior to discharge. Caesarean section is also an extremely convenient time at which to insert the copper IUD, and for that reason, we should, as I mentioned earlier, counsel all pregnant women about the possibility of IUD insertion during caesarean section in case at the time of labor there should be an emergency caesarean section. And as for tubal ligation, one does not want to be trying to conduct this conversation in the middle of an emergency. So we should counsel pregnant women during the antenatal period with advice discussing that if she were to end up for any reason having an emergency caesarean section, would she like us at that time to either do a tubal ligation or provide her with a reversible method such as insertion of the intrauterine device. So the device can be inserted at caesarean section either manually, just holding it between the front of the third finger and the back of the second finger and inserting it to the fundus. And then the threads are just directed down towards the cervix. The second method that we can use is to leave the IUD in its insertion tube in the open position, without tucking the arms into the tube and without the plunger, and just pass the lower and pass it up into the fundus with the tube, and then we can pass the lower end of the tube through the cervix, and after caesarean section, remove the tube digitally via the vagina. Alternatively, we can just use the tube to pass the uterus up, pass the IUD up to the fundus of the uterus and remove the tube there and then. But just be very cautious during the closure of the uterotomy not to pick up the threads of the IUD which are lying free in the uterine cavity. Immediate postpartum insertion is a very important opportunity for IUD insertion. The advantages include that women are highly motivated at this time to have some contraception, and also it's convenient in that it doesn't involve an extra trip to the service provider to have the IUD insertion. And also, of course, there's no need to exclude pregnancy at this time. The disadvantage compared with interval insertion is that the expulsion rates are higher than with interval insertion, somewhere between 5 and 10%. But this disadvantage is outweighed by the fact that far more women are actually able to receive the IUD when a postpartum service is offered. The IUD needs to be inserted within 48 hours after birth, and if this window is missed, one then needs to wait for 4 weeks before doing an interval insertion, because between 48 hours and 4 weeks, there's an increased risk of uterine perforation. So as I've said, we should counsel women during the antenatal period so that at the time of delivery, they have already made up their mind or had the opportunity to choose intrauterine contraception with the intrauterine device. Post-placental IUD insertion can be done within 10 minutes of delivery of the placenta and before the uterus has contracted by holding the IUD between the second and third finger, as shown here, not side by side, but one finger in front of the other, and immediately passing the whole hand right into the uterus and up to the fundus and leaving the IUD at the fundus. One should, of course, exclude contraindications such as postpartum hemorrhage, and one needs to wear a long sterile glove with the extra long cuff. More commonly, we use a method of insertion with a forceps such as the Kelly forceps or a swab holding forceps, And this should ideally be done in the labour ward before the woman is discharged to the postnatal ward, though it can be done in the postnatal ward as well. If perineal suturing is needed, it's best to administer the local anaesthetic, wait for that to work, then insert the IUD before doing the suturing. And as I said, if the opportunity is missed in the labour ward, the IUD can be inserted in the postnatal ward. We need to ensure that the mother's been fully counselled on her choice of a family method and emphasise that the IUD is one of the most effective methods, but nothing is 100%. The IUD is effective for at least 12 years, but may be removed at any time, and that she should expect heavier or crampy menstruation, which usually settles in a few months. We ask the mother to empty her bladder, and we need to have a lighter torch or a head torch available. We need ideally a long Kelly's forceps, a swab holding forceps, and a SIM speculum and cleaning solution, and a sterile surface to work on. If a Kelly's forceps is not available, we can use a second swab holding forceps. It's a little bit more difficult, but quite possible to insert without the Kelly's forceps. We position the mother with her buttocks over the end of the bed, her feet either in stirrups, or they can just be held up with her hands over her knees or resting on the bed as shown in this picture. We partially open the IUD back and remove the plunger and the straw, and then observing sterile precautions, we pass the Kelly's forceps or the swab holding forceps into the sterile container and hold the left arm, or actually as we're facing it, the right arm of the IUD, which will be on the mother's left, with the stem directed a little bit away from the forceps, so that when the forceps are removed, the bead at the bottom of the stem and the thread will not be hooked by the forceps and pulled out. The copper IUD T380 strings are usually about 11 centimeters long and need not be trimmed. 60% will descend through the cervix during involution of the uterus, and if bothersome, they can then be trimmed to 3 centimeters visible length at the 6-week visit. For IUDs with longer strings, there are two options. One is to trim them also to 11 centimeters, or to trim them to 3 centimeters visible length after insertion, realizing that they may need to be trimmed further after involution of the uterus. We clean the vulva and perineum with a cleansing solution such as chlorhexidine in water, dilute chlorhexidine in water. We very gently insert the speculum over the perineum, or we can use 2 fingers to depress the perineum. Then we cleanse the vagina using the one swab holding forceps. Then use that same swab holding forceps to grasp the anterior lip of the cervix. And we may need a light or a torch to visualize this. We then insert the IUD into the cervix, keeping it close to the anterior wall and avoiding contact with the vagina. If necessary, the swab holding forceps can be held in the palm of the left hand, as shown in the middle picture here, so that 2 fingers can be used to part the vulva during the insertion. We remove the speculum and then direct the forceps anteriorly, aiming towards the umbilicus. And at this point, we can also remove the forceps holding the cervix, or it can be steadied by an assistant. With our other hand, we then abdominally push the uterine fundus posteriorly to align it better with the axis of the vagina. We then slide the uterus up to the fundus of the uterus, and there should be absolutely no resistance to the insertion. If resistance is felt, this means that the IUD is being caught at the junction between the lower and the upper uterine segments, and it's necessary to pull back a little bit Alter the angle, usually more anteriorly, and gently try and reinsert. If this is not successful, one can actually use the forefinger of the right hand, as shown in the lower picture, to guide the tip of the forceps and the IUD through that rather narrow junction between the lower and the upper uterine segment and into the upper segment. And once it's at the fundus, we need to confirm that position by gently palpating the presence of the forceps at the fundus. And this can very easily be palpated transabdominally. We then open the jaws of the forceps, move this forceps away from the IUD to the right, in other words, to the mother's left side, and then withdraw the forceps position to avoid snagging the bead or at the bottom of the IUD or the strings. If we're uncertain about whether the IUD is in the correct position, we can use transabdominal ultrasound to assess the position of the IUD in the postpartum uterus. We remind the mother to report back if the IUD is expelled, or if the strings become bothersome, or if she suspects that she's pregnant in spite of the IUD. And of course, always encourage the mother to use condoms, as the IUD does not prevent against infection. We encourage the woman to attend a 6-week postpartum visit, at which time we do a speculum examination to identify the threads, and if needed, to trim them to 3 centimeters visible length. If they're not visible, we can insert a retriever or a sterile throat swab into the uterus and retrieve the strings with a twirling motion. If the strings are not retrieved, we can confirm the presence of the IUD with an ultrasound. If a woman requests removal of the IUD with strings not being visible in the vagina, we can similarly use either the retrieve it or the sterile throat swab in the uterus to retrieve the strings with a twirling motion. And if that's unsuccessful, we can use small crocodile forceps or an IUD hook or an endometrial biopsy curette to locate the IUD within the uterus or hook onto it and retrieve the IUD. This is just the Memeory aid we use in our training for postpartum IUD insertion. It sort of follows the first letter of the number to some extent. So 1 is to cleanse the vagina, 2 is to insert the SIMS, 3 is to cleanse the vagina, 4 is forceps to hold the anterior cervix, 5 is forceps to hold the IUD, 6 is to slide the IUD up the anterior lip, 7 is to remove the SIMS, 8 is to angle the handle of the forceps backwards, 9 is to negotiate into the upper segment, 10 is to take the forceps off the cervix, 11 is to elevate the uterus backwards, 12 is to take the IUD up to the fundus, 13 is to touch the IUD at the fundus, 14 is to open the forceps, 15 is to slide the forceps to the side, and then 16 is to slide out the opening. And it's very important that care providers, both doctors and midwives, are trained with a formal training program for postpartum IUD insertion, including counseling skills training, didactic training on the postpartum IUD training, simulated training on a mannequin, and clinical insertion under supervision, and certified at least 5 correct insertions under supervision before the provider continues to do the insertions. So I hope that I've covered most of the important factors, aspects of the topic. And I'd just like to end by emphasizing again how important it is that women who, well, firstly, we can say women who wish to have children should be assisted wherever necessary to reach their childbearing uh, um, wishes, but for women who do not wish to be pregnant, we should make sure that at every contact with the health services, we are in a position to counsel them fully and to make sure that they have access to the contraceptive method that they choose, and that this important preventive measure will have enormous health benefits for the woman and for society, and will help us in achieving our goals to reduce both maternal and perinatal mortality. Thank you very much for listening.